This is the different solar radiation and the skin. This is the spectrum of skin. Ultraviolet B, the length of this rays is almost 290 to the 320 nanometer, and ultraviolet A length is 320 to the 4 nanometer, and the length of the visible light is 400 to 7 nanometer. So this wavelength is, if it is below the 290 nanometer and above that, it is normally filtered by the atmosphere, and it is not cause it not cause any toxicity on the skin. Only these wavelengths are energetic enough and prevalent to include the cutaneous toxicity. So the wavelength between the 290 to the 700, it is only produce the toxicity on the skin. Otherwise, below 290, it cannot produce any toxicity on the skin. Phototoxicity, an acute adverse reaction resulting from the exposure to the photoactive chemical plus light exposure. Key clinical features are rapid onset. So there is you can see the redness and blistering. You see here, this is the redness and blistering you see after exposure of the light on the skin. And a common exposure is the ultraviolet A. So this is ultraviolet A wavelength is between the 320 to the 400 nanometer for the phototoxicity on the skin. And this is the example of the tar spot. The coal tar in the combination with the sunlight produce an immediate stinging sensation that may later result in the hyperpigmentation. So first in the tar spot, first you can see this type of lesion, and later on it converted into the hyperpigmentation. This is the mechanism of the phototoxicity. So the wavelength between the 290 and 700, when it come in contact with the skin, so and if the skin have some photosensitizing the drug, so in the acute case, is all the direct toxicity. There is a damage of the membrane lipid and protein damage and DNA damage, and it lead to the carcinogenesis. So in the acute case, you will see the direct damage, and it may lead to the carcinogenesis due to the DNA damage. And in the chronic case, it causes the activation of the Langerhans cell, and there is a proliferation of the T cell. So you can see the inflammatory lesion on the skin in case of chronic inflammation, in case of chronic case. Sorrow lungs, a facial case. So this sorrow lungs normally used during the PUVA therapy. The mechanism, unlike the many phototoxin, sorrow lungs do not require the formation of the signet oxygen. It take action like they intercalated into the DNA, and upon UVA activation form the covalent adapt and cross-link into the DNA, resulting in the inhibition of the DNA synthesis and repair, and it leading to the cell death. So by this way, it produces the toxicity. It is naturally present in the food, such as like lime and celery. So this is normally present in the lime and celery. So if you have any allergy and any sensitivity due to the lime and celery, you can find the toxicity of this. Historically used in the PUVA therapy for the condition like psoriasis with associated with the long-term risk, because this PUVA therapy contains the sorolon, and it may cause the phototoxicity. Phototoxic effect on nail. Nail phototoxicity, drug and topical applied chemical may induce the adverse effect in the nail. Like in the onycholysis, detachment of the nail layer is the most prevalent sign. So here you can see the detachment of the lower layer of the this nail. It is mainly due to the phototoxicity. In a photodynamic photolysis, like effect from the coal tar and tetracycline require the reactive oxygen species. So for this toxicity, this chemical required to produce the reactive oxygen, and due to that it produces the toxicity. Photoallergy and immunologic reaction. It is a delayed type hypersensitivity reaction that requires the photoactivation of the allergen. The onset is it develop over hour to days, may persist for several weeks if the allergen is retained in the skin. Unlike the phototoxicity, photoallergy occurs with the low dose exposure, and it is mediated by the T cell. This is the historical example, like high cases of the photoallergy from the halogenated salicylic cyclanide in the 1960s and to 70s. So during this period, there is a exposure of the halogenated salicylanide observed in the world. So it is most for the photoallergy. More recent concern involves the sunscreen agent and topical NSAID like ketoprofen. It is responsible for the this photoallergy. So how we can diagnose the photoallergy in the human? So this is same test like patch test earlier we have seen for the cumulative chronic dermatitis. So in this test, the photopatch test identified by the photoallergy contact dermatitis by testing a substance reaction when exposed to the ultraviolet light. Two identical set of the allergen are applied. So here two patches will be applied to the skin and using the patches and left for keep for 24 to 48 hours. So after application, you have to keep it up to 2 days. And after removing the patches, one test site is exposed to the ultraviolet A radiation. It is normally 5 joule per centimeter square, while the other remain unexposed. So this site is remain unexposed, irradiated, and this is uh, irradiated with the ultraviolet A. Both sides are evaluated at 48 to 72 hours for the skin reaction. A positive reaction only at the irradiated site indicate the photoallergy. So see here, this is the normal side without irradiated. So there is no any reaction. But in UVA exposure site, you see the positive response. So this compound is considered as a photoallergic. In this page, there is a positive response, but there is a no exposure to the radiation. Here also there is a positive response, plus there is a exposure of the this UVA. So this response is +2. So it is also considered as this is the contact allergic, plus it is also considered as a photoallergy. Here also you can see the plus and plus. So this is not photoallergic, but this is the contact allergy because you have not increased the intensity after the application of the ultraviolet radiation. Molar extinction coefficient. The molar extinction coefficient is a measure of how strongly a chemical compound absorbs the light at the specific wavelength. This is a very important criteria to test to check whether the compound is photoallergic or not. If the higher the MCE, like if the higher MC, the more efficient a molecule absorbs the light at the wavelength. So if MEC is less than 100 L mole minus C centimeter square, the chemical pose the little or no toxicity and photoallergic area. So when you select the any compound for the any thermal compound, so you have to first check the molar extinction coefficient of the compound. If it is less than 100, less than 1000, then there is a less chances for the phototoxicity or photoallergy. This is the in vitro test used to check this phototoxicity. It evaluates the cytotoxic potential of the chemical as a predictor of the acute phototoxicity. It used the BALC3TA3 mouse fibroblast cell exposed to the test chemical with and without the ultraviolet radiation. Cell viability is assessed by the measuring the uptake of the neutral red dye, which accumulate in the healthy cell. So it is a significant decrease in the viability in the ultraviolet exposure group and compared to the non-exposure group indicating the phototoxicity. So this is the cell, this is the procedure. You have to cell seeding in the well. You have to keep the cell on this well, and after that you have to apply this neutral red reagent, and then you have to go for incubation for 4 hours. And then this absorption reading at 540 nanometer. If there is a more uptake of the neutral red, it indicates the healthy cell. And if there is a less uptake, it indicates the non-viable cell. This is the interpretation of the cell, this test. In this, you can see the PAIF. The PAIF equal to IC50 without ultraviolet A. It divided by the IC50 with ultraviolet ray. IC50, we know the IC50 is the concentration causing the 50% cell viability. So by using the result of this PIF, if you establish the IC50, if you establish the IC50 in the study, then you have to use the PIF to interpret this test. If there is no establishment of the IC50, then you have to use this MPE for interpretation of this test. So when there is a no phototoxicity, PIF value is less than 2 or MP is value less than 0.1. If there is a equivocal phototoxicity, then PIF value is greater than 2 and less than 5, and MPE value is greater than 0.1 and less than 0.15. The phototoxic compound, you can see the PI value is greater than or equal 5 or MP value is greater than or equal 0.15. This is the in vitro method used for the photoallergic to test the photoallergic to determine the potential of the chemical to activate the keratinocyte and dendrite cell in photoactivated state. So this is the no two test currently using for this photoallergenicity. Photokeratinosense assay uses the human keratinocyte transfected with a reporter to assess the gene expression changes after the exposure to the UVA. And UVA exposure should be typically the 5 joules per centimeter square. Photo HCl test involves the human dendritic cell line assessing the changes in the cell surface marker like CD54 post UVA exposure. So this is currently two tests are using in vitro for to test the photoallergenicity. This is the another disease endogenous photosensitivity. It is the photosensitivity arise from the inherent cellular and genetic or biochemical abnormality. This factor, like both endogenous and exogenous factor, can be responsible for this disease. And this is a chemical example of the endogenous also photosensitivity disorder, like xeroderma pigmentosum. During this disease, a genetic defect resulting in the impaired repair of the ultraviolet light-induced AML. So in this disease, once if you damage with the ultraviolet, then the skin don't have a capacity to regenerate. So this is the picture of the xeroderma pigmentosum. And second disease is the systemic lupus erythematosus. And autoimmune condition marked by an abnormal sensitivity to UVB. Although the precise mechanism remain unclear, so this is the you can see the mainly lesion you can see on over the skin. This is the systemic lupus erythematosus disease picture. The third disease is the porphyria. It is the hereditary or chemically induced porphyria. Enzyme deficiency disturbs the heme synthesis. Accumulation of the photoporphyrin precursor in the skin lead to the sponsor photosensitivity upon the exposure to the visible light 400 to 410 nanometer wavelength. This is the second type of porphyria. Porphyria cutanea tarda can be precipitated by the alcohol, estrogen, or certain antibiotic in susceptible individuals. So this is the normally the hereditary or chemical induced porphyria, and this is mainly due to the endogenous photosensitivity, and this is the due to the alcohol, estrogen, and certain antibiotic. Pellagra. This is also one type of endogenous photosensitivity. In the pellagra, result from the altered tryptophan metabolism, which can be drug induced or maybe genetically. It is characterized by the photodermatitis, diarrhea, dementia, and sometimes you can see the death of the person, and it is treated with the niacin because in this disease there is a disturbance of the tryptophan metabolism. Electromagnetic radiation. So earlier we have seen that the wavelength of the radiation is 290 to 700. This radiation only can reach to the Earth. It is UV, ultraviolet B, ultraviolet A, and visible light. The radiation beyond this range is filtered or insufficient energetic. So you can here you can see the differentiate of the skin color. So this is the redness of the skin is due to the electromagnetic radiation, and it is a phototoxicity. And below that there is a fair skin you can see. So there is no any phototoxicity due to the electromagnetic radiation. In this, you can see the erythema. The minimum erythema dose varies with the skin pigmentation. It is mediated predominantly by the UVB. The wavelength of the UV is 290 to the 320 nanometer with vasodilation and inflammatory mediator release. So here you can see a type of design. And then systematically, you can see the fever, chill, and malaise can be accompanied the severe sunburn. If there is a severe sunburn, then you can see the fever and chills. Also, personally, most of people have seen when they are exposed in sunlight in the summer. So due to their more exposure, you can see the fever. So this is normally due to the electromagnetic radiation. Mechanism of the ultraviolet induced skin changes. UV is the most effective in the producing the erythema. It is the less evident in the sunlight. UVA is the up to 10-fold more evident than the ultraviolet B, and approximately 1,000-fold less efficient per unit energy in the generating the erythema. The cellular molecular effect like erythema accompanied by the keratinocyte injury and DNA damage, and then the release of the inflammatory mediator from the injured cell. When there is a DNA damage, then it leads to the skin cancer. When there is a long-term exposure, the chronic UV exposure, photoaging and decrease the Langerhans cell density and increase the risk of skin cancer, because due to the decrease of the Langerhans cell density, the immunity of the skin will decrease. So there is a chances of more lesion, and ultimately there is a chances of skin cancer also. Chronic exposure, photoaging, and photocarcinogenicity. The clinical manifestation of the chronic ultraviolet exposure is photoaging. Photoaging is the premature wrinkling, skin thinning, and easy bruises. This is the main clinical sign of the photoaging. In the pigmentary changes, the prattling, idiopathic, gutted, and hypomelanosis you can see in these pigmentary changes. Pre-cancerous lesion like the actinic keratosis and orokeratosis you can see in the as a precancerous lesion. The malignant lesion like basal cell carcinoma, squamous cell carcinoma, and malignant melanoma you can see is a malignant lesion due to the this chronic exposure of the phototoxicity. Underlying mechanism like cumulative decrease in the Langerhans cell impair the immune surveillance. So we have seen that when there is a decrease of the Langerhans cell, then there is a decrease of immunity of the skin, and which leads to the skin cancer also. Permanent DNA damage lead to the oncogenic transformation also you can see due to the phototoxicity. Pigmentary response to the ultraviolet exposure. It is it is two type: immediate response and maybe delay type of response. The immediate pigment darkening you can see due to the photo oxidation and occur within the minute. The tanning it develop over days due to the increase the melanin production. Tanning is normally the delay type of pigmentary changes. So we know that the melanin present in the skin, which is responsible for the protect the skin from the ultraviolet radiation. So if a person who have a deficiency of the melanin pigment, then there is a chances of more phototoxicity in that person. This radiation also have some beneficial effect, like it is also responsible for synthesis of the vitamin D in the skin. In therapeutic phototherapy, artificial UV source used for the treatment of the psoriasis, vitiligo, and other skin disorder. So there is in this also for this skin radiation use. Blue light therapy like blue light like 420 to the 490 nanometer wavelength. It is photo convert the bilirubin in the skin. This is very useful in the neonatal jaundice disease, and it is normally present in the neonate. While UV exposure has reached the controlled dose yield vital physiological benefit. So if exposure in the control limit, then it very useful for the therapy. But beyond that limit, it causes the phototoxicity. Urticaria, it is also known as hives. The urticaria present as red, itchy, and sometimes the staining drills on the skin. So this is the lesion of the urticaria. So here you can see the clinical sign and typically appear within the minute after exposure. Wheels are open reddish and may be localized or widespread. So in the second image, you can see the redness of this skin lesion. It is the lesion of the urticaria. It is also known as the hives is the common term used to describe this lesion. Immunologic basic of the allergic urticaria. It is the type 1 hypersensitivity reaction mediated by the immunoglobulin E antibiotic found to high affinity receptor on the mast cell. The mechanism is the re-exposure to a trigger lead to the cross-linking of the IgE and causing the rapid mast cell degranulation. So this is the mechanism by which way the immunogenic the response you can see in the allergic urticaria. Key mediator is the histamine along with other vasoactive substance in the release and accounting for the redness, swelling and itching. Immediate vs non IgE mediated urticaria. IgE mediated urticaria is triggered by the food allergen, drugs and environmental protein. It is rapid onset within 1 minute upon the allergen exposure. Non-IgE mediated mechanism like some agent like opiate cause the direct histamine release from the mast cell. So it is also responsible for the urticaria. Nowadays, the NSAIDs may induce the urticaria by affecting the arachidonic acid metabolism or via the other pathway. Trigger and allergen in urticaria. Mainly the food allergen like nuts, peas and shellfish, which is responsible for the urticaria. Pharmaceutical like antibiotic penicillin, cephalosporin, sulfonamide, macrolide. It is also responsible for this disease. Insect venom like bees and wasps sting can provoke the anaphylactic and as well as the localized urticarial reaction. Sometimes the contact allergen urticaria you can see like from protein like natural rubber latex. It is the main example of the contact allergen and it is also responsible for the urticaria. Melanin and normal pigmentation. First, we see the melanocyte function. The melanocyte produces the melanin. It is crucial for the protecting the skin against the harmful UV radiation. So this melanin is absorb the UV radiation. So there is a very less chances of the phototoxicity. Melanin is synthesized by the series of the oxidative reaction involving the amino acid tyrosine and the enzyme tyrosinase. The role of melanin is to absorb the ultraviolet light across the UVB and visible spectrum, help to mitigate DNA damage in keratinocyte, thereby reducing the risk of photo-induced skin cancer. Mechanism of the pigmentary disturbance. So how when the any UV radiation come in contact with the skin, then this pigment is very responsible for prevent the damage. But when there is a pigmentary disturbance, so this mechanism is responsible for the phototoxicity. Certain chemical like phenol, catechol, quinone disturb the normal melanogenesis. So it disturb the synthesis of the melanin and it lead to the phototoxicity. Many agents become the substrate for tyrosinase, leading to the production of the reactive oxygen species that are toxic to the melanocyte. So many chemicals are also produce the reactive oxygen in the skin and that lead to the damage of the melanocyte and it lead to the phototoxicity. Alteration of the signaling pathway. Some drugs affect the melanocytic signaling, like inhibition of the c-KIT tyrosine kinase by the imatinib mesylate. This is the compound which inhibits the c-KIT tyrosine kinase, which is very important for the giving signal to the melanocyte. And due to this signal, there is a production of the melanin. If this signal is inhibited, then there is a less production of the melanin and less protection from the ultraviolet radiation. Paradoxical reaction may also occur, leading to the hyperpigmentation in the selected area also. This is the another disease of the skin, hyperpigmentation or depigmentation. Reduction or loss of the melanin leading to the lighter patches of the skin frequently result from the chemical exposure where the metabolite via tyrosinase activity generate the reactive oxygen species which damage the melanocyte. And due to the damage, it affect on the production of the melanin and which lead to the skin disease. Example is the monobenzyl ether, historically found in the rubber gloves. So rubber gloves this contain the monobenzyl ether, which cause the licoderma. Means this compound is responsible for the decrease the melanin synthesis. So due to the decrease, there is a change in the color, or you can see the whiteness of the skin. Other agent like exposure to the chemical phenol and catechol also responsible for this hyperpigmentation. Disorders such as vitiligo, it is an autoimmune disease and drug-induced melanocyte toxicity. So sometimes it also produces the autoimmune disease, and this lead to the hyperpigmentation and lipodema. Pigmentary alteration in the nail. Systemic exposure to the certain drug like phenolphthalein, arsenic, silver, anti-neoplastic and anti-malarial drug may cause the nail bed and pigmentary changes. So here you can see the pigmentary changes on the base of the nail. This is maybe due to the some exposure of the some compound. Clinical sign like pattern and location of the nail pigmentary changes can assist in diagnosing the drug-induced nail disorder. So you have to see the lesion in the nail and location of the these pigmentary changes to identify and differentiate from the other disease. Now the next disease is the acne. This is the common disease observed in the human. The acne is the common condition affecting the pilosebaceous unit of the face, chest, and neck. Can see in the picture there is a one example of the picture of acne in the face and one example of picture of acne in the back. Uh, Clinical signs like more frequently encountered within the puberty due to the hormonal influence. So this is the common due to the hormonal changes you can see in the human in the during the age of 15 to 18-year age. This is the common symptom you can see in the girl. It involves the blockage of the sebaceous duct, sebum retention, bacterial proliferation, and subsequent inflammation. So, this is first cause is the blockage of the sebaceous duct. So, due to the blockage, there is a accumulation of the sebum inside the skin, and due to this accumulation, there is a chances of bacterial infection, and this bacterial infection lead to the inflammation. So, here you can see the normally the affected area are the face, chest, and back. The photographic illustration of the technique for the representation in the worker exposed to the cutting oil. You can see in this case of acne. So this is the anatomical presentation of the how acne occur, and this is the hair anatomy histopathology of the hair also. So in this compound hair follicles, you can see this is the hair follicles and sebaceous gland and duct. Sebaceous gland produce the sebum and which lubricate the skin and nail. This is the normal process for sebum is normally secreted to the skin surface and maintain the skin hydration and barrier function. So how acne occur? So in acne, you can see in the pubertal age also, and due to the hyperproliferation, abdominal proliferation of the ductal cell lead to the retention of the chondrocyte, and due to the blockage of the this follicular orifice lead to the sebum retention and gland enlargement. So if you see in this picture, so this is the normal shaft of the hair, and this is the uh, sebaceous gland. When there is a blockage of the opening of this shaft, there is a chances of retention of this sebum, and this sebum, due to the retention, there is a chances of bacterial inflammation, and this bacterial inflammation lead to the inflammation. So by this way, there is a production of there is a chances of acne vulgaris in the skin. Chloracne, a disfiguring acne form eruption due to the exposure to the halogenated aromatic hydrocarbon. Positive agent are the chloroacnizone, including the polychlorinated biphenol, naphthalene, polychlorinated dibenzofuran, and dioxin. The exposure source are the industrial process, environmental disaster, and military exposure also lead to the chloride. This is the image of the chloride. This is normally present in the ear, near to the eye and shoulder, back, nose, and genitalia. The associated sign is the hypertrichosis in atypical location, hyperpigmentation, brown discoloration of the nail, conjunctivitis, and eye discharge you can see in this disease. Pathogenesis is the progressive degeneration of the sebaceous unit, transforming of the sebocyte into the keratinous cell. Hyperkeratosis that block the follicular canal, and proposed mechanism exposure to the chloracnizone may shift the differentiation of the sebaceous follicular stem cell into the epidermal cell. This is the pathogenesis of the chloride. Some historical examples are also present for the chloride. During the Vietnam War, Agent Orange exposure was linked to the chloride among the returning veterans. Environmental disaster like Sevastopol in Italy explosion released the tetrachlorobenzopidioxine. It is also responsible for the production of the chloracne. Chemical contamination in the rice pudding oil in the Japan during the 1968 and Taiwan during the 1979. It is also responsible for the chloracne in the human. The recent case is the Ukrainian president Viktor Victor Yushchenko for poisoning and subsequent diagnosis made by the Dr. Jean Hilary Saurat and colleagues. So this is the recent example of the this chloracne in the Ukraine president. Granulomatous disease. This is the next disease of the skin. A foreign body reaction that isolate the injected or inside the substance in the skin. It is the two type, like non, it has the total two type non-toxic reaction is the inert substance that do not produce the inflammation. So this is the carbon tattoo. This is the image of the carbon tattoo. In this tattoo, the graphite deposit from the lead pencil injury resulting in a persistent gray dot with the minimum inflammation. So in the second image, if you see in the image B, there is a angle of the this graphite by the macrophage you can see, and the proliferation of macrophage you can see at the site of carbon tattoo. Toxic granulomas, substance like the silica or talc that cause the macrophage activation and may lead to the complication like bowel obstruction. Silica is the powder in surgical gloves can transform into the colloidal particle that activate the macrophage. So this is the this is the known example of the this granulomatous disease due to the surgical gloves. And they currently regulatory has banned the powder medical gloves due to this reason. Immunogenic granulomas reaction mediated by the T cell that can mimic the chronic infection. Some example like paraffin and mineral oil injection can induce the sclerosis like lipogranulomas in the skin. Beryllium skin lesion analog to lung granulomas from the beryllium exposure. Other agents like the T2 dye and metallic compound, it is also responsible for the renal metastasis. Sclerodermatosis skin disorder. In this disease, skin induration, tightening, and hardening, you can see may present with the Raynaud phenomena, calcinosis, and telangiectasis in the systemic cases can affect the blood vessel, heart, lung, kidney, and digestive tract. The pathophysiological insight is the abnormal collagen deposition lead to the impaired tissue flexibility and function, and overproduction and accumulation of the collagen in the body tissue. An historical example like the toxic oil syndrome seen in the Spain during the May 1981. This is the historical example of the sclerodermatosis skin disorder. Toxic epidermal necrolysis. Toxic epidermal necrolysis is the rare and life-threatening skin disorder characterized by the widespread epidermal detachment greater than 30% of the body surface and severe mucosal erosion. Epidemiology like incidence 1 to 2 cases per million per million person per year you can see, but up to the 100 times higher in the age patient. So if a person have the age, it is very susceptible to the toxic epidermal necrolysis. In this disease, widespread skin detachment, blistering, and erosion, you can see there is also severe erosion in the gastrointestinal, respiratory, ocular, and genitourinary mucosa. You can see mechanism of this disease in the TN is the immune-mediated cytotoxic T cell reaction leading to the widespread keratinocyte apoptosis. So in this disease, this is mainly due to the apoptosis of the keratinocyte. Damon-Jones syndrome affects up to the 10% of the skin and has a lower mortality. Overlap exists and when 10 to 30% of the skin involved. This is the other example of skin disease. Etiology of the TN. Over the 200 drugs implicated, major group include the anticonvulsant, non-steroidal anti-inflammatory drugs, sulfonamide and allopurinol. This is the main drug are responsible for the TEN. Other potential causes like infection, malignancy, and vaccination may also contribute for TN. But this sometimes genetic defects like strong association between the HLA-B 1502 and carbamazepine induce the TN in the Han Chinese. So nowadays, regulatory also impose that the regulatory agency now recommended the genetic screening for the Asian patient due to this genetic disturbance. Hair anatomy and growth cycle. It is composed primarily of the keratin. The cortex provides the mechanical strength and contain the melanin. This is the different part of the this hair. You can see this is the external shaft of the hair, internal shaft of the hair. This is the bulb of the hair. So this is the different structure of the hair, and this is the different growth phase of the hair. There is a total 4 phase. The anagen phase, it is considered as the active phase. It is mostly 3 to 6 years. You can see for anaphase. The kenagen phase is a transition phase. It is only for 1 to 2 weeks. This is the picture of the telogen phase. This is the resting phase. It is you can see for the 3 to 6 weeks. And after that, it is converted into the anagen phase. So there is a new growth of the cell. So this is the cycle you can see throughout the growth of the hair. Toxic effect on the hair, anagen effluvium. Uh, this is the acute hair loss during the enagen growth phase. So earlier we have seen during the this phase toxicity we can see in the enagen effluvium. The common cause is the systemic exposure to the cancer chemotherapy agent. So we know that when anybody have this cancer therapy, there is a hair loss normally seen in the person. Heavy metals such as mercury, bismuth, and palladium also responsible for this enagen effluvium. Historical example like thallium salt were once used for the tinea capitis. So previously thallium salt are used for the treatment of the tinea capitis, and it caused the hair loss, and due to the this toxicity nowadays people are not using the thallium salt for the treatment of the tinea capitis. Toxic effect on the hair. This is the hypertrichosis, means extra overproduction of the hair, excessive hair growth resulting from the stimulatory effect on the hair follicle. Etiology is the drugs such as minoxidil, anabolic steroid, which are two main drugs which are responsible for the overproduction of the hair. It also association with the certain cancers and eating disorder. Hexachlorobenzene exposure, which linked to the porphyria cutanea tarda, and also called the hypertrichosis in the human. Uh, it distinguishing between the toxic induced hypertrichosis and the pattern hair growth alteration is critical for the patient management. So it is very difficult to identify or differentiate between this due to the certain disturbance in the hair growth, or it may be due to the toxic induced hypertrichosis. Now, UV induced skin cancer. The prevalence of the skin cancer is over 5.4 million cases of the non-melanoma skin cancer observed in the US, and it was 3.3 million people in the 2012. Basal cell carcinoma, it is almost 4 million cases per year, normally seen in the United States. Squamous cell carcinoma, it is approximate 1 million cases per year observed in the United States. Melanoma, although it is less than 1% of the skin case cancer, it was most skin cancer related death. So in case of the melanoma, you can see the death almost less than 1% in the United States. There is also lifetime risk. Approximately 1 in 5 Americans will develop the skin cancer. This is the recent data survey done by the United States. In almost 1% out of the 5 American has the cancer, and out of this cancer, 40 to 50% of the American age 65 plus develop at least one basal or squamous cell carcinoma. So this is the squamous cell carcinoma incidence. Incidence is very big in the this United States. High risk group. Organ transplant patients are nearly 100 times more likely to develop this squamous cell carcinoma due to mainly due to this immune suppression of the immune system in those patients. Individual with genetic condition like xeroderma pigmentosum in the face dramatically increase the risk of skin cancer. This is the molecular mechanism for the skin cancer. Ultraviolet B induce the formation of the pyridine dimer and pyrimine dimer and 8-oxo-guanine lesion. So when any skin is exposed with the ultraviolet B, there is a formation of pyrimidine and 8-oxo-guanine lesion. This cause the DNA damage and lead to the mutation, and this also inhibit the P35 tumor suppression gene. So this P35 tumor suppression gene is responsible to prevent the tumor in the body. But when there is an inhibition of this gene, which lead to the cancer, it inactivation destabilize the genome, provide the initiate cell growth advantage. UV-induced immunosuppression may also facilitate the tumor cells survival. So this is the picture of UV radiation. Skin cancer lead to UV radiation. There is main uh, 3 point is responsible for this skin cancer like immunosuppression, DNA damage, and oxidative damage. Later on, it is responsible for the carcinogenicity. The three-stage model of the skin carcinogen. First stage is the initiation, promotion, and progression. So in initiation, when the any UV light is come in contact with the stem cell, and after the come in contact, there is a clonal expansion of the initiated cell within generalized hyperplasia. So during the this case, there is a transverse progression of the cell, and after that there is a vertical progression of the cell growth you can see due to the overgrowth of the pre-malignant tumor, and this vertical growth we known as the papilloma, and later on it convert into the malignant, and it causes the metastasis, and due to the metastasis it spread throughout the body and produce the skin cancer. With the molecular mechanism of the chemical induced skin cancer, in this chemical induced skin cancer, the PAH are relatively inert but accumulate in the cellular membrane. They undergo the metabolic activation via cytochrome P450 enzyme, and then due to the DNA damage, oxidative biotransformation produce the reactive electrophilic epoxide that form the DNA adapt. Further oxidation lead to the formation of the electrophilic quinones and reactive oxygen species, resulting in the additional DNA damage. And by this way, it produces the skin cancer. Prevention of the skin cancer, daily use of sunscreen, which reduce the squamous cell carcinoma by 40%. It also reduced the melanoma risk by 50%. This is the recent data observed in the US. So normally the US, almost all people in the US using the sunscreen to prevent the prevention for this skin cancer. And the annual cost for the this skin cancer is almost $8.1 billion in the United States. And out of these, $4.8 billion for the non-melanoma skin cancer and $3.3 billion for the melanoma skin cancer. With the UA increase, the attention is given to the skin cancer as a occupational disease among the outdoor workers. So currently they have established the many policy for the outdoor worker to prevent them from the skin cancer. This is the most example of the arsenic. Arsenic, we know the arsenic is a skin cancer and carcinogen. It is abundant element found in the low level in the air, water, and food. Historically, example like previous used in the it was used in the medication and also used in the pesticide. Now largely eliminated in the high dose from the developed country. Current source like environmental exposure from mining dust, melting fume, contaminated waterways, and food preservative are significant contain the arsenic, and it is mainly responsible for the carcinogen. Globally, high well water arsenic concentration threaten the tens of billion in the Bangladesh and India. So in the India and Bangladesh normally will contain the arsenic due to the contamination of water with the pesticide, and it is the main cause of carcinogen in the Bangladesh and India. Even in the United States, arsenic in the drinking water remain a concern. They have changed the criteria for the concentration of arsenic in the water from 50 ppb to the 10 ppb. Okay, thank you.